Nearly half of the deaths of children under 5 are linked to undernutrition, and this is occurring mostly in low and middle income countries. My name is Sara Jerving. I'm a journalist with Devex covering global health. Today, we're talking with 3 experts about their efforts to tackle malnutrition. Dr. Asaf Bitton is Executive Director of Ariadne Labs at Harvard T.H. Chan School of Public Health, and he will discuss the center's strategies around tackling malnutrition. We're also going to discuss malnutrition amongst children who were born with cleft lip or palate, which is a particularly vulnerable group of children because of the problems that they have with breastfeeding. Dr. Miriam Nabie is a nutritionist based in Western Kenya. She works with the international charity Smile Train, which provides free cleft and palate surgeries to children. We'll also be joined by Schaefer, who's President and Chief Executive Officer of Smile Train, who's going to walk us through the organization's 5-year plan around reducing malnutrition. Thank you so much to everyone for joining us for this session. Dr. Bitton, what sort of work is Ariadne doing around malnutrition?
Well, thanks so much, Sara. It's really a pleasure to join you today. And, I'd really sort of frame the work that we do in malnutrition really in the larger frame and context of our overall work. We're a health systems innovation center built within both academia and active partnerships around the globe to try to identify and solve for what we call no-do gaps, the gaps between what is known in public health and clinical practice and actually what happens. And unfortunately, those gaps across the world are actually responsible for greater increases in morbidity and mortality than the lack of access to care. So these quality gaps are what we focus on. And our teams initially started focusing on almost a decade ago, really trying to improve child outcomes and perinatal outcomes in and around birth using a checklist approach developed with the WHO and trialed in a number of large randomized controlled trial settings. And what we found is that, while coaching and implementation of these techniques at the facility level could improve birth and perinatal and feeding practices, they weren't enough to really change mortality. And so where we are today is, given the recognition that there are approximately 20 million infants born every year that weigh less than 5.5 pounds, we're really focusing on low birth weight infants that are at the highest risks of suffering disease, poor growth, and death. And so there is a lack of information even these days about what are the best feeding options for these infants in low and middle income countries. And to close that gap, both of knowledge and of practice, our Better Birth team has joined 10 partners around the world to launch what we call the Low Birth Weight Infant Feeding Exploration Study that was launched in 2019 that is following infants and families in Tanzania, Malawi, and India for the first 6 months of their life. And actually we expanded it to the first year of life to really understand how growth, immunization, overall well-being really relate to differential types of feeding practices all around the globe.
And in what ways should the global health community kind of restructure nutrition programming so that these programs are more effective?
Right, it's a huge question and such a critical issue given both the extent of the issue, the challenge to essential health services in the time of COVID, and the increasing vulnerability and nutrition challenges, both due to climate change and ongoing pandemics. I think at least 2 areas. Number one, I think, and we've talked about it for decades in health and development, but it really is something we need to emphasize, is the integration of nutritional programming and strategies into and around 2 big areas. Number one, primary healthcare. Really seeing primary healthcare and primary healthcare efforts as not just being clinically mediated, only focused on clinical pathways and around vaccinations and other preventive and promotive things, but really seeing nutrition as fully integrated with a primary healthcare approach and seeing nutrition fully integrated in public health programs so that it isn't seen as another vertical. It isn't seen as just a supporting feature for other vertical programming in the global health space. I think widening the aperture one level further, I think that we really need to think about what are the pathways that we think about nutrition as being part of both inducing vulnerabilities at the infant, family, and community level, and also as a potential solution to those vulnerabilities. So there are sets of vulnerabilities around women's agency, access to resources, social vulnerability, biological vulnerability. Then there, childbirth and perinatal and postnatal causes sort of induce further vulnerability and challenges, and that's where we really need to integrate all of these approaches and not see sort of nutrition as simply the delivery of food to hungry communities, but really as part of the entire global health and development platform to reduce the sort of induced vulnerability that's programmed from social, biological, and other context-laden causes.
Thank you so much for that. So myself and a photographer visited Dr. Nabie's nutrition clinic in June in Western Kenya, where we took a look at her team's efforts to improve nutritional outcomes for children born with cleft lip and palate, and to ensure that they are strong enough for surgery. So here's a video we produced documenting the story of one of her patients.
Kwa majina naitwa Sharon Nafula wa Mocha. Jifungua, nilibarikiwa na mtoto anaitwa Travis Mayama. Harakati nilikuwa najifungua, alipotoka nje na mtoto, daktari akaniuliza, unajua kitu kinaitwa cleft lip? Nikamweleza sijui. Mtoto akaweka kwa incubator. So baadaye wakaniambia, mtoto wako atakuwa na shida ya hataweza kunyonya. Kasema mbona hataweza kunyonya? Ati kuja umuone. Sasa nikaenda kumuona, nikaona kweli mdomo vilako. Hata nikashtuka. Nikasema sasa hii ni nini shwali?
Travis came to us immediately. She was born. He was born in the night at around 2 a.m. Kim was referred to Dreamland at around 6 or 7 a.m. in the morning, so that was pretty fast. It was a case that we expected this child will be able to breastfeed with just the right techniques taught to the mother. However, the mother did not have breast milk for some time. And it bothered us because we didn't understand why the mom still doesn't have milk. But it was more associated to the stress that she was going through, having the family sort of disowning them or not claiming her as one of their own, because first she had a kid at such a very young age, she was just in school, and then worst of all, it's a cleft. They have never seen a cleft. It really affected her because she could not get the care she was used to getting from home. So she did not have milk at all.
And that time sikuwa na maziwa kwa nini matiti. Kuna kitu inatoka. Sijui ilikuwa hiyo stress ama whatever. Challenge ni ile nilikuwa watu wakikuja wanamuona. Anasema, wewe ulifanya aje mtoto? Ulikula nini? It seems there's some food yenye ulikuwa unakula ukiwa mjamzito. Mtoto akakuwa nayo shida. Kanyamaza. Wengine wanasema hapana. Hizi ni some of the laana za kwenu tu maybe ama huku.
We provided them formula milk for the first few days just to be able to get the baby to feeding something at least. But we still encourage the mom to continue positioning, allowing Travis to be able to try and breastfeed with the proper attachment positions that we taught them. So it worked. For some time, Travis was able to get breast milk. It was only that it was not enough to sustain him to be able to be full and stay full. So Travis went on to continue with formula milk up to until I think by 5 months. We transitioned him to a simple porridge with just one starch to still make it more heavy for him. By the 5th month, Travis was on millet porridge with some groundnuts in it, and he could take the porridge really nicely. He started gaining weight and he now obtained that proper curve that we wanted. Travis' surgery was quite delayed because we could not get him to have the right HB level, like the blood level to be at a good point for surgery. So we started him on supplementations for iron, which was to help build up his blood level. Thankfully, we finally achieved it, and we're really looking forward to having his surgery done.
So, Dr. Nabie, even though these nutrition services are accessible at your clinic to children with cleft, there are also barriers to families accessing care. Can you talk a bit about some of these challenges?
Thank you very much. For children, for families who have children born with a cleft lip and a palate, there is still a lot of community stigma around children born with a cleft, which is really a big barrier towards them coming to seek for the care. In most cases, you'd find a mother is sent away from the community because they have a child with a cleft. And just having the support around them to encourage them to come to the facility to access care for their child is always a very big problem. Sometimes there will be disowned, like just the story we have seen in the video, and it becomes a very big hindrance. And also for some communities, there's just a lack of an awareness about where to go to seek that care for their child who is born with a cleft. Because we still have very rural communities who are not aware of even the services we offer at Dreamland and many other Smile Train partner hospitals to do the cleft repairs. Or sometimes there's just some misinformation. They would associate a cleft with something like a curse or something like witchcraft or like a blame in the family, and that misinformation really misleads the mother, and they would think it's something that got to them and there's almost nothing they can do about it. And of course, there's just that financial burden that is attached to the whole journey of care. For instance, for a mother coming to the facility, and because of the feeding challenges, we expect them to keep coming again and again. And for some, they live as poor people, and therefore they almost own the poverty, and they believe that there is no way they can afford that. So, of course, there's a lot of information that we're sending out to the community and awareness about their services being available and being free, but it's just a journey. It takes quite some time for the whole community to change that about the thought about what they know about cleft. And also something that we're really moving away from is just basically misinformation about even from the professionals, the medical professionals. I think cleft has been overlooked for some time, and much as it has been learned in school, but they don't practice it for most of the time, then they wouldn't know what kind of information to give a mother with a child who has a cleft. And of course, for most of them, they'll give them wrong information. Oh, there is no way you can breastfeed this child. You'll have to go for this other option. And by the time they get to the care that you're providing them, they already have so much false information that dispelling it also takes some time. So yeah, that's just basic summary about what barriers are faced by such families. Thank you.
Okay, thank you. So Susanna, a Smile Train has some ambitious goals for what it plans to accomplish in the next 5 years in its work around nutrition. What are these goals and how does Smile Train plan to achieve them?
Thank you, Sara, and thank you to Dr. Bitton and Dr. Nabie for sharing your insights and experiences. Listening to you both reminds me not only of the important work happening in the nutrition space around the world, but also the remaining work needed to meet the global targets for reducing stunting, wasting, low birth weight, and the many grave outcomes of malnutrition in children. Studies suggest that people with disabilities are 3 times more likely to be malnourished and 2 times more likely to die from malnutrition. At Smile Train, we see these numbers reflected in the faces and the stories of too many children and families impacted by cleft lip and palate. We know that achieving our vision of a world where every person has access to safe, high quality, comprehensive cleft care and is able to live a full and healthy life requires inclusive nutrition programs that support mothers and babies impacted by clefts. Our nutrition programs have been expanding over the years, led by incredible people like Miriam and local Smile Train medical partners around the world. COVID has only served to underscore the urgent need for these programs. And that's why today at the 76th UN General Assembly, I am so proud to announce Smile Train's 5-year commitment to scaling our investment in global nutrition. By the end of 2026, through awareness campaigns, advocacy, program expansion, partnerships, training and education of health workers, Smile Train's increased investment in nutrition will result in more than 1 million mothers and children benefiting from cleft-specific feeding counseling, more than 55,000 child malnutrition cases averted, over 40,000 educational opportunities on cleft feeding and nutrition, more than 1,000 partner hospitals across over 70 countries empowered to offer nutrition services to every mother and child pair affected by cleft. Over 250 partner hospitals in an organized network offering advanced nutritional care for malnourished children affected by cleft, and a 40% reduction of the number of stunted children undergoing cleft surgery. When it comes to nutrition and to protecting the health of communities and securing the future of children around the world, we cannot delay. In the chat, there's a link to our website to learn more, to contact us, and to track progress on these 5-year targets. This is a call to action and an invitation to join us in prioritizing nutrition for all children, including children with clefts. Thank you, Sara.
Thank you so much, Susanna. And I really look forward to watching Smile Train's progress on these goals in the coming years. And thank you to Dr. Bitton for your thoughts on using an evidence-based approach to tackling malnutrition, and Dr. Nabie for describing your work in Western Kenya. And thanks to everyone who joined us for this important discussion.